for those of you I haven't met, I'm Stacey Cruz, one of the inpatient hospitalists. And interestingly, before I came to Georgetown, and before I lived abroad for a couple years, I worked as a primary care doctor also. And so this talk kind of combines my two areas of experience, the typical outpatient problems and what we do with them in inpatient. I've never given this talk as a Zoom talk. It's generally quite interactive. I know that I shall not expect that for today. But I will say, please feel free to unmute yourself, to jump in. And also, if it's not a good time to jump in, go ahead and type in the chat box, and Travis will be watching our chat box for us. So I am going to turn my video off and get on with things. Maybe. There we go. Okay, so I have no relevant disclosures other than the fact that I like to show off pictures of my kid and dogs, so you'll see a few throughout the talk. This is him just a couple weeks ago when I gave him my first haircut to him. So today we're going to touch on a couple high-yield topics. These are things that we see inpatient all the time. And I'm going to focus them into three areas: hypertension, COPD, and anemia. And of course, those are my dogs, Yoshi, the brown one on the bottom, and Abby, the black one on top. Okay, so we're going to start with a case. We have a 61-year-old woman coming in from the ED with an infected left lower extremity ulcer, diabetic ulcer. She's debrided in the OR, and you're taking care of her post-op on the medicine service. She has a history of hypertension and type 2 diabetes. Her home medications are lisinopril, chlorthalidone, amlodipine, and metformin. All were held on admission except amlodipine. You check on her as she returns to the floor from the PACU, and vitals are afebrile at 36.8, heart rate 94, respiratory rate 14, blood pressure elevated at 188 over 102, and she's satting 97% on room air. She's a bit groggy after waking up from surgery and complains of left lower extremity 6 out of 10 pain, but otherwise appears well. Her nurse sees the blood pressure number and asks you, "Doc, what are we going to do about that blood pressure?" So I want you guys just to take a second before we go into this to think about what are some of the considerations that are going to go in your decision about what you're going to do about the blood pressure. So think through that for just a sec. Think about what you're going to evaluate, what questions you're going to ask. Okay, so the first thing you want to think about, as you probably thought about, is this a hypertensive emergency, right? So is this something I need to deal with right here, right now, fix this blood pressure as soon as possible within the next hour? And how are you going to figure that out? So think about the different causes of hypertensive emergency and what questions and physical exam findings are going to help you figure that out. So we're going to look at the cardiopulmonary exam, right? We're going to look for crackles on lung exam. We're going to look for JVD, see if she's having flash pulmonary edema, maybe a new murmur, maybe an arrhythmia, if she's having some sort of cardiac issue. We're going to check out her mental status, right? So we're thinking about, could she possibly be having something like PRESS, where her blood pressure is immediately affecting her mental status. We want to know what her kidney function is, because AKI is one of the markers of emergency and hypertensive emergency. And if we are thinking about, does she have any chest pain? Does she have any shortness of breath? Where is it radiating? Is she high risk? We're going to do an EKG if it's indicated. So again, when you see that number, the first thing you want to think about is, okay, is this an emergency, or do I have a little bit of time to think through and deal with this? Other things you want to think about is, well, what can I fix, right? So blood pressure is not always a problem on its own. It can be an indicator of a problem. So there are lots of potential reasons that patients in the hospital especially can have high blood pressure. So for example, we all know pain increases blood pressure. Likewise with anxiety. Some of the lesser known things is that nausea can actually increase blood pressure through receptor feedback in the brain, as well as bladder distension. So that's a common one in somebody who's post-op or maybe has BPH, and they're unable to urinate. That's going to cause hypertension. And then always remember that patients may be in withdrawal, whether from alcohol or other drugs, and that might be the reason that their blood pressure is elevated. So all of these things, you need to treat the underlying cause, not the blood pressure itself. And then finally, am I doing anything to cause it? Are we doing anything to this patient here in the hospital that might be causing their high blood pressure that I need to address? And so the most common ones are going to be hypervolemia, right? So if somebody's hypovolemic, they tend to be hypotensive, and it's actually the same in the opposite. Hypervolemia causes hypertension. And then there are a number of drugs that can cause hypertension. And I'm not going to go deep into drugs now, but we'll name a few on the next slide or two to think of some of the common ones. So we're reviewing her OR records. She got 2.5 liters of normal saline. So remember, normal saline is a large part sodium. That's going to cause volume expansion and potentially hypertension. And she also received a dose of ketorolac, which is an NSAID in the PACU for pain. And NSAIDs have the potential to increase blood pressure as well. So there's some potential reasons that she might be having hypertension right now. So now we're going to check for hypertensive emergency. We're going to look at her heart sounds. They're regular, no new murmurs or gallops, nothing notable, no arrhythmias. Her lungs are clear, no evidence of flash pulmonary edema. Her JVP is about 9, reasonable amount for somebody who's post-op and just got 2.5 liters, not necessarily overloaded. Her mental status is completely normal. We go ahead and check a creatinine, and it's right about at her baseline, so she's not having AKI. And though she's not having chest pain, she has some risk factors for ischemia, so you go ahead and get an EKG, and there's no evidence of ischemia. So we've gone in our head through the possible scenarios for hypertensive emergency and found out, okay, this is not an emergency. I have some time to think through and deal with this before intervening right away. So my question for you guys is, what would you like to do at this point? We can give her IV hydralazine or labetalol, get that pressure right down real quick. We can give her IV morphine, address her pain. We can give her IV Lasix, get rid of some of the extra fluid that she got in the OR. She's clearly not volume depleted. We can start oral hydralazine or labetalol. These aren't her medications, but they work rather quickly and pretty reliably, and we can titrate them quickly. We can resume her home medications, lisinopril and chlorthalidone, or we can do nothing and recheck in 30 minutes. Maybe the measurement was bad, maybe this is just transient pain, maybe if we do nothing at all, it'll come down on its own. So I'm going to give you a second to think through, what would you be most likely to do? If you're on night float, you're called at midnight, nurses really want you to do something about that scary number, what are you going to do? Think about it for a minute. Okay, so let's think about, what do the guidelines say, right? We like to have evidence, we like to have guidelines to tell us what to do in the hospital. Well, there are guidelines for blood pressure management in hypertensive emergency, which includes, but is not limited to, stroke, ACS, dissection, acute heart failure. So we know that there are guidelines for that, what percentage do we want to get the blood pressure down and in what period of time. But that doesn't apply here. She's not having hypertensive emergency. There's also the JNC8 and the ACC-AHA guidelines on blood pressure, but those also don't apply. Those are strictly for ambulatory patients outside of the hospital setting. There is actually no evidence at all that treatment of hypertensive in the acute hospital setting outside of the hypertensive emergency world improves mortality or morbidity. So the question is, well, why should we treat this if it's not an emergency immediately? There's actually not even evidence that an elevated BP on its own is a significant risk, except when there is acute end organ damage. And so a lot of times when I talk to people about this, they say to me, well, yeah, maybe there's not end organ damage right now, but we don't know when she's going to develop a stroke or have a MI or something like that. We got to get this blood pressure down to prevent those things. It's a very common thought and probably the driving reason behind why we are sort of tempted to treat those high scary numbers when we hear them. But interestingly, there's been studies on that. And if a patient's not already presenting to you with end organ damage, just a high number on its own is not an indication that they're going to progress. And in fact, the vast majority, greater than 99%, do not progress to any end organ damage or hypertensive emergency. So evaluate for emergency up front, but if there isn't one, it's highly unlikely that you're going to head towards an emergency in the near future. And so because of these things, there are actually no guidelines at all for asymptomatic blood pressure elevations in hospitalized patients. So we're kind of in low evidence territory here. So let's think through some of our common options. I'm sure all of us have either seen or ordered ourselves IV hydralazine. It's a quick and easy way to get that blood pressure down, decrease the number of pages you're getting at night. So why not use that? Well, there's a prospective study at a university teaching hospital, just like ours, that followed all patients except for those in the ICU, ED, or OB unit. So potential hypertensive emergency patients were excluded, who had just an order in the computer for IV hydralazine over a 6-month period. So they just looked at everyone who had the order and what happened with these patients. So over that 6 months, a total of 94 patients received 201 doses of IV hydralazine. And I was actually kind of surprised at how small that number was. I feel like, every day one of my patients in the morning has gotten IV hydralazine overnight. 48% of those doses were ordered between 11 p.m. and 7 a.m., again, reinforcing the fact that, things are more difficult at night. You're covering a whole bunch more patients you don't know, you don't have time to think through things, and sometimes just fixing the number is the expedient way to address things. Unfortunately, only 7.5% of the patients were evaluated by a physician before the hydralazine was ordered, and only 17% after ordering the hydralazine. So the vast majority of patients were never seen by a physician, never evaluated. They just got the order to decrease the number, probably without much more thought than that, unfortunately. When looking through the chart review of these patients who got the hydralazine, only 2% actually had diseases for which aggressive blood pressure lowering could be indicated. So for example, only 2% had either hypertensive emergency or something that could be thought of that needs to be further evaluated for hypertensive emergency. So 98% were asymptomatic blood pressure elevation. And of the patients who got the hydralazine, 8% of doses resulted in an adverse event. So way more adverse events than patients who actually potentially needed the blood pressure lowering. And so some of those with hydralazine, sort of unsurprisingly, is hypotension, right? So hydralazine is a potent vasodilator. And so, it's kind of unpredictable how patients are going to react to it. Some have a small lowering of their blood pressure, some have a drastic lowering. From that, you can get orthostasis, symptoms, obviously, dizziness, lightheadedness, palpitations, nausea, vomiting, diaphoresis, chest pain. Again, because of this quick drop in blood pressure, can cause symptoms. And the one thing that wasn't evaluated in this study, but that I actually see pretty frequently here in the hospital, is when they have these big drops in blood pressure, the next day you'll see an AKI from poor perfusion of the kidneys. And so this study didn't actually look at what percentage of these patients actually developed an AKI as a result of the treatment of their asymptomatic hypertension. So because of this, if any of you have rotated with me before, I don't know who's on the call right now, but I have probably talked extensively about, or maybe not extensively, but at least some point about IV hydralazine. In my view, there is very, very infrequently ever a reason to use IV hydralazine. Because if you're having a hypertensive emergency, that's not the medicine you're going to use, right? You're going to titrate it drip, use something with much more control. And if it's not an emergency, you're much more likely to cause problems and side effects than do any any good with IV hydralazine. So this is one of my most hated medications, and if I see it the morning of admission, I will immediately delete it and think through what other options do I have. And so this is kind of a nice flow sheet, like thinking about those same concepts that we went through. Again, the first question is the patient symptomatic? Obviously, we're going to address symptoms and any emergency that's there. And then thinking through all the different things that can be contributing. So again, anxiety, pain, nausea. I purposely put this in multiple times so that you have the repetition and think through all these things before reflexively reaching for medication. Think through withdrawal, think about volume. Usually overload, although in some cases volume depletion can cause reflex sympathetic tone. Pretty uncommon though. Think about what we're doing to the patient. Are we giving them NSAIDs? Are we giving them some pathomimetics, other stimulants? A pretty common one in younger people is going to be oral contraceptives or other hormones are going to cause hypertension. In our population here at Georgetown, we have a lot of patients on Takehome for transplant, and that can cause hypertension. And I'm not going to go through the rest of them, but you can look through their medication list and see what might be causing that. And then think about, okay, well, they were maybe admitted for surgery or they were vomiting or something like that. Are any of their home medications on hold? There's absolutely no reason to reinvent the wheel if they're already on a home medication that we know is working, we know they're tolerating, and we were just holding it for one reason or another. Okay, let's go ahead and restart their home medication. And then finally, after all that thinking, all that evaluation, if their blood pressure is consistently elevated and significantly elevated, right, we expect it to be a little higher than baseline in the hospital, then we're going to go ahead and consider either maybe we need to increase their current blood pressure medications, maybe we need to add a new agent orally, not IV, and remembering that it's going to take, days to maybe weeks for these to take full effect. And so another common mistake I'll see is, okay, one day we'll increase the carvedilol, then the very next day, like, oh, it's not working, let's add some amlodipine. The very next day, oh, let's add a chlorthalidone. And then 1 week later, their blood pressure's in the tanks because we forgot to let things sort of self-equilibrate after we made all these major changes. So unless there's drastic situations, ridiculously high blood pressure, I generally won't make more than 1, maybe 2 changes every 2 to 3 days or so for titrating blood pressure medications in the hospital. Because remember, they're asymptomatic. We just learned that they're not likely to develop any immediate complications from their high blood pressure. So think to yourself, what would I do if this patient walked into my clinic, right? So I'm a primary care doctor now, they're walking into my clinic, they have a blood pressure of 188 over 102. Am I going to send them to the emergency room for that? No, I'm not. I'm going to say, okay, start this new medication or double this medication and come back and see me in a week, 2 weeks, something like that. I got to give them some time for these things to have some effect. So moving on with the same patient. She's now recovering nicely on post-op day 3. Pain is now well controlled. She's only on as-needed Tylenol. She's eating and drinking normally, not getting IV fluids. You've resumed her lisinopril, her chlorthalidone. She's still on her home amlodipine. Her labs are normal. And so we look back, and since that post-op day 1 with the elevation, her blood pressure measurements have been steadily averaging above 160s over 90s. So clearly above where we want her to be as an outpatient per our ambulatory guidelines. She's going to be in the hospital for 1 or 2 more days of IV antibiotics, so you potentially have some time to address this before discharging her. So what do you want to do next? And again, I want you guys to think through some possibilities before we talk about it. So, none of her medications are at their max dose. Do you want to increase one of her home medications? If you do, which one and why? Or do you not want to do anything and have her follow up with her primary care doctor in a week and mention, like, hey, her blood pressures were elevated in the hospital. Maybe this needs to be addressed as an outpatient. So again, think about what you would do and why. All right. So let's again think about, okay, well, what considerations are going to go into my decision? What am I going to think through in my process of making this decision? So first of all, is proper blood pressure measurement technique being used? I can 100% guarantee you in the hospital, it's not. They're rushing in the room, waking up the patient. They're not sitting them up. Their feet are not on the floor. Their back is not supported. Maybe their cuff is like hanging off their arm. Maybe it's the wrong size cuff. So all of these things. So, before you address the data here, you want to know, is this good data, or are these numbers just junk numbers that I don't need to worry about? Another consideration is, well, what are her home blood pressure measurements like? If she tells me, I take my blood pressure at least once a week at home, it's rock solid normal on my regular medications, I've never had an issue, my doctor thinks my blood pressure is great, I would be a lot less likely to make adjustments, because I know once I get her to her home environment, she's likely to be lower blood pressure than she is now. On the other hand, if she tells me, yeah, I've been checking my blood pressure regularly, it's always elevated no matter when I take it, where I take it, my doctor's been bugging me about it, well, okay, maybe I'll be more likely to adjust her medications, knowing that sometimes when things are done, when I have the chance to do them, I know it's going to happen, rather than maybe being lost to follow up, or maybe the message getting lost with her PCP. Same kind of idea. What are her blood pressure measurements like in her PCP's office? How often does she see her PCP, right? If she's someone who's like, yep, I go once a month or once every 3 months without fail, I've known my PCP for 10 years, well, then maybe I'm not going to mess with what they're going to do, because they might have different considerations than I have. They clearly know the patient better than I do. And so maybe I won't make adjustments. On the other hand, if she hasn't seen her PCP in a year or 2 years or something like that, well, they're not going to get a chance to make an adjustment, so maybe I better do it now while I have a captive audience, essentially. How quickly can she get in with her PCP, right? So, some of us can make an appointment this week, and some of us have called our PCP and been told, oh no, you got 1 or 2 month wait before you can get an appointment. And patients will generally know that if they see their PCP regularly. They can say, oh yeah, they always get me in on a pretty easy basis. If you're going to make any medication changes, well, you're going to need to tell the patient. So how are you going to explain to her? Is she going to understand the information, remember the information? Are there other caregivers involved in her care who are going to need to know this information? And likewise, how are you going to communicate this to her PCP, right? So she might go back to her PCP with all these crazy medication changes as far as they're concerned, and they're like, oh no, just go back to what you were on before, and so your changes did absolutely nothing unless you're able to get this information to the next physician to see her. And so again, if you go back to what the guidelines say, well, they still don't apply, right? So again, these are the JNCA, the ACC, AHA are only for ambulatory patients. She is not currently an ambulatory patient. The environment in the hospital is different than her environment at home and about. And again, there are no guidelines for asymptomatic blood pressure elevations in a hospitalized patient. So, honestly, the answer is you could go either way, kind of depending on those factors that we talked about. Any one of those options might be a reasonable decision. So if you decide, you know what, she's got a good relationship with her PCP, maybe her numbers are good at home, I'm not going to change anything right now, let's do this in the outpatient setting. One thing to keep in mind is that there's emergency medicine literature that notes that when a patient comes into the ER acutely hypertensive and nothing is addressed, as in, they say, oh, go follow up with your PCP, that actually correlates with no changes in their medications at all, so non-treatment of their blood pressure in 6 to 18 months. And so again, the question is, how reliable are they going to be in follow-up? Are they going to be lost to follow-up? So we don't want to not do anything and then have inertia do its thing and nothing is ever done. So we're going to clearly communicate to the patient, well, this has been high, I think it needs to be addressed, you need to go see your PCP, this is the time frame you need to go see them in, etc. Clearly communicate. And again, clearly communicate to the PCP. Her BP control wasn't optimal, maybe this should be rechecked as an outpatient, consider increasing her medications. And the important thing is making sure the discharge summary gets to the PCP's office. Now, luckily in this hospital, as long as you list the PCP correctly on the discharge summary, my office, the hospitalist administrative office, sends PCPs to everyone, or sends discharge summaries to everyone listed on the discharge summary. So as long as it's listed, it's going to be sent. But if it's something time critical, those are the times when you print it out yourself, fax it yourself, email it yourself, make sure that information gets to the next person. And then again, ensure the patient has a follow-up visit or can get a follow-up visit. Okay, well, maybe she's not the most reliable. Maybe her blood pressure has been elevated for a long time and she needs an adjustment. So, okay, let's go ahead and adjust it. Well, one thing we need to remember, again, is it's going to take days to weeks to see the full effects of your adjustments. And so you don't want to make a bunch of adjustments quickly. 20% of patients discharged from the hospital will have some adverse drug-related event after discharge. So for every 5 patients discharged, 1 is going to have a problem with their medications after discharge. So again, a reason to really think twice about, is this a good choice for this particular patient, or am I going to cause them a problem? Again, we need to clearly communicate this to both the patient and the PCP. And again, ensure the patient has timely follow-up. Okay, so I'm going to take a quick break right there. This is my son when he learned to ride a bike. I believe this is actually his 6th birthday as well, and my 2 dogs looking extra cute. I'm just going to take a break and say any questions about the hypertension section, because we're going to move on after that. Please feel free to unmute yourself or use the chat box.
I'm just very jazzed that you're doing this topic, Dr. Cruz, because I remember on night float as an intern, I got hammer paged by a nurse for 4 or 5 times because their blood pressure was like 186, and it was exactly what you just walked us through. So
yes, and the one thing that I didn't say in the talk, which is highly practical advice, is sometimes explaining all this to the nurse is the best treatment.
Mm-hmm.
All right, well then I'm going to go ahead and move on, but again, please feel free to stop me, jump in, put a chat in the chat box if questions come up. Let's see. Okay, so we're going to move on to a new case. We have a 73-year-old man who's got COPD, BPH. He's admitted for COPD exacerbation. He's got a long smoking history, but he quit 2 years ago. He's only mildly symptomatic with his COPD at baseline, and he's been managed as an outpatient with just as needed albuterol, which he uses a few times per week. His only other medication is his tamsulosin, Flomax, for his BPH. This is his 2nd hospitalization for COPD this year. His exacerbation is successfully treated with the typical means: oral steroids, duo nebs. At first you do them scheduled, then you space them out to as needed, and oral antibiotics. So he's completed his full course. You're getting ready to discharge him. You've already scheduled him an appointment with his PCP in 5 days. So the question becomes, what medications will you discharge him on? So here are some of your options, and this is sort of a pick one or more than one. Do you want, what as needed medications do you want? Just albuterol, just ipratropium, both together? What long-acting medications, if any, do you want? He wasn't on a long-acting before. Does he need one? Do you want a LABA, a LAMA, corticosteroid? And or is this somebody who needs a prophylactic dose of azithromycin? So think about that for a second. Okay, so this is a table of management of stabilized COPD based on the GOLD classifications. And obviously, I'm not going to read this out to you. I only put this here to reinforce the fact that there are actually guidelines for this, unlike our last topic. And the GOLD classifications are based on symptoms and risk. So our patient that we have here actually has pretty infrequent symptoms. They're mild at home. They don't bother him all that much. He uses his albuterol a couple times a week. And so we're less worried about managing his day-by-day symptoms. What we're worried about in our patient is his risk of recurrent exacerbations. So if he's had more than 2 exacerbations a year, or 1 or more leading to hospitalization, or especially if he's been in the unit on BiPAP or intubated, he's very high risk for recurrent exacerbations. and we need to make a choice based on that. And so if you look at the guidelines for this specific category, category C, low symptoms but high risk, our first choice treatment is a long-acting muscarinic agonist, a LAMA, which is somewhat surprising because we tend to think, trigger for our first thought for COPD is often Advair or Symbicort, our combination LABA and steroid. So let's think about that a little bit. So LAMAs, the most common of which is tiotropium or Spiriva, brand name, is found in studies, and the studies are referenced at the bottom, to be superior to salmeterol, which is a long-acting beta agonist, in COPD, in exacerbations per year, in time to onset of the first exacerbation, improvement in FEV1, improvement in symptoms, and improvement in quality of life. So it's all pretty robust evidence, all these things where the LAMAs are superior to the LABAs. In addition, practicality-wise, tiotropium has the added benefit of being once daily instead of twice daily. And if any of you guys have ever tried to take a twice daily medication, you are twice as likely to forget a dose. And so as we just said, because of these reasons, LAMAs are the first choice treatment in GOLD category C, low symptom but high risk COPD. And if that's not enough, if the patient's still having further symptoms or further hospitalizations, the next best option will be adding the long-acting beta agonist. Let's talk a minute about inhaled corticosteroids because, we see these used so often in asthma. And unlike in asthma, ICSs should only be used as a part of combination therapy. They should never be used as monotherapy alone in asthma. In COPD. This is the opposite of asthma, where the first inhaled medication is going to be an inhaled corticosteroid. So this is one of the big differences in the treatments between asthma and COPD. This is because in COPD, the long-acting bronchodilators have greater benefits with fewer adverse effects. So remember, the underlying pathophysiology is different in these diseases, even though they overlap quite a bit. So although COPD does have an inflammatory component, really the ICSs have a minimal effect on the inflammatory pathway of COPD. It's really the other components of COPD that drive symptoms and risk, and those are what you want to address with the bronchodilators. The time when you do particularly want to use ICSs in COPD is when there is a significant component of asthma overlap. Because again, asthma is a largely inflammation-driven disease. You want to decrease the inflammation so that you prevent exacerbations, whereas the long-acting medications are mostly just Band-Aids to help with the symptoms that come from that inflammation. And then in addition, there are studies that show that ICS treatment in COPD in particular increases the risk of pneumonia compared to no ICS treatment. So if you are, on your last option, you've added every other medication there is, you can go ahead and add the ICS. It is indicated, but just remember that it does increase the risk of pneumonia. So again, this is sort of a zoom in of the GOLD ABCD classification based on symptoms and risk. I'm going to greatly simplify this to a cheat sheet. Again, this should be like your first thought, but remembering that it's more complicated than this, and you should think through this a little more than, excuse me, the simplified cheat sheet. So GOLD A is less symptoms, low risk. Really, all they need is a short-acting bronchodilator. Either class works well, but the combo of the two classes works best. In GOLD Class B, they're low risk. They're not having a lot of exacerbations, hospitalizations, but they are more symptomatic on a day-to-day basis. Well, this is where you kind of have dealer's choice. Whichever long-acting medication better controls the patient's symptoms is the one you want for them. And so it may take some experimentation. And then sometimes practically this also has to do with like, okay, well, what's most covered by their insurance? Because as we all know, inhaled medications are some of the more expensive medications that we use commonly. GOLD Class C, which is lower symptoms but high risk, we just said the first choice should be a long-acting muscarinic. tiotropium. And in Gold Class D, where they have more symptoms and high risk, generally those are the patients you're going to have on both long-acting medications, plus maybe an ICS if needed, plus maybe they're on prophylactic azithromycin and some other treatments. They're probably seeing, or they should be seeing, a pulmonologist by this point. So we're going to keep thinking about this same patient, our man here. So he's discharged on scheduled tiotropium because we decided to pick a LAMA for our first choice treatment, plus as needed albuterol. And we're going to make sure he's taught proper technique for both type of inhalers. Remember, every inhaler is different, and so just because somebody knows how to use one doesn't mean they properly know how to use another. He's also referred to pulmonary rehab, and he does very well over the next year with no exacerbations, no hospitalization. So that's great, really decreased his risk. However, during the following influenza season, and I will say I created this talk before COVID, so we're just going to ignore COVID for right now. He is again admitted to the hospital with an acute exacerbation triggered by influenza A. So the only other interval change to his medical history is finasteride has been added for worsening LUTs from BPH. So you write your admission orders, you're going to give him the steroids, you're going to give him oral oseltamivir for the flu, regularly scheduled duonebs for symptom control. And as you're completing his med rec, you have to check the box yes or no on whether you're going to continue his tiotropium during his acute exacerbation. So what are you going to check? So first, let's talk about tiotropium plus ipratropium. Is there too much of a good thing? Well, the duration of action in the long-acting, the tiotropium, is actually decreased during an acute exacerbation, which makes sense because you're not getting as much of the medication deep down into the lungs. So it's actually not going to last 24 hours. And so if you are going to continue it at the beginning of an exacerbation, you might have a decreased effectiveness of it in those last few hours or more before the next dose. If you combine tiotropium and ipratropium to try to get over this sort of hump, if you will, kind of use that ipratropium to get you those last few hours, there is a small increase in FEV1 when you add them together. However, it's pretty minuscule, and it's really not clear whether this is clinically significant at all. However, when you combine the two, you really increase your risk of anticholinergic side effects. And the most common one, the one we worry most about and see the most, is going to be acute urinary retention with the combination of these two medications. And men with BPH are obviously at the highest risk for this. So, okay, well, what if we just do the tiotropium alone and not do any ipratropium? What happens if we do that? Well, interestingly, there was a study published at our sister hospital, Washington Hospital Center, in 2008, that looked specifically at, well, what if we add early tiotropium, so not the first day or two of exacerbation, but start it early, replace our ipratropium with tiotropium in patients admitted for COPD exacerbation. What happens then? Well, in the study, the need for rescue treatments, so acute inhaled bronchodilators, decreased by 30%. So you could say that patients were less symptomatic based on that. The length of stay was decreased by a whole day. And, maybe at first that doesn't sound like much, but in length of stay research, this is huge. Like, we get excited about, 0.5 of a day or something like that. So this is actually a really huge difference, excuse me, and saving a lot of money for the hospital system. The overall cost of their treatment in general was decreased. But one thing to note is that Hospital Center already had a protocol in place for the early addition of formoterol, which is another long-acting beta agonist. And so the tiotropium wasn't added until after the formoterol had already been added. So this doesn't answer the question, okay, well, what if you tried to do the tiotropium first, since we just said it's a better first choice medication in certain situations. But I think it's still a really reasonable study about how we can decrease costs and decrease length of stay. And I'm not going to go terribly into this, but two things that I thought were interesting here is when you look at the total cost of the bronchodilators, so just adding up everything they use, both long and short acting, after the addition of the tiotropium protocol, the total cost of the bronchodilators went down. So again, we're saving the hospital system money. And one thing that I was less aware of earlier in my career is what is the relative costs of all these things? And one thing to note, so for example, for our short-acting albuterol, if you give albuterol nebulized, super cheap, 40 cents. I mean, that's barely anything for one dose. If you give it with an MDI, it's much, much more expensive. And this is per dose. So remember, you're giving multiple doses per day, multiple days. That really adds up quickly. And one of the reasons for this is that MDI formulations were changed probably 10 to 15 years ago now because of chlorofluorocarbons were outlawed. And so because of that formulation change, all these MDIs got a new patent. And so none of these medications, except for very, very recently, are generic. And so that's one of the reasons they're so expensive. But then if you look at the long-acting medications, the formoterol and the tiotropium, when you compare them to the short-acting albuterol, for example, they're much less expensive. And so that's kind of, and then they also added in this cost of the spacer, the nebulizer kit, the respiratory therapist, and that's how they came up with this lower cost per admission. So the bottom line here is if a patient is on a LAMA, in general, their rescue treatment should be a short-acting beta only. So don't combine a LAMA and a SAMA. If they're not on a LAMA, then a combination of both short-acting, oops, sorry, that's a typo. This should be short-acting for both, works better as a rescue treatment than either alone. So duonebs works better than either albuterol or ipratropium alone. A long-acting and a short-acting beta agonist may be used together, so that's perfectly fine. And when a patient's hospitalized and starting to improve past that early acute exacerbation point, consider the early addition of a long-acting muscarinic antagonist or beta agonist and adjust the as-needed therapy appropriately. Okay, so this is my reminder in my talk that hour-long talks are no fun, especially when they're not interactive. It's after lunch. You guys are probably a little bit sleepy. So I'm going to pause here. And I know I can't see you, but I'm going to tell you, you need to stand up and stretch for a minute. And while you're standing up and stretching, waking yourselves up, let me know if there's any questions on COPD. Seriously, stand up and do it. Okay, moving on to our last section of the talk. We're going to be talking about anemia. So we're now admitting a 41-year-old woman with ulcerative colitis, hypertension, CKD stage 3, and GERD. And she's coming in with a colitis flare. Her home medications are lisinopril, chlorthalidone for hypertension, omeprazole for her GERD, and mesalamine for her UC. But she has not been able to afford the mesalamine for the last month. So unsurprising that she's coming in with a flare. You note that her hemoglobin is 10.4. Other labs related to her anemia workup include a low normal MCV, a low iron level, a high normal TIBC, a low transferrin saturation, a low normal ferritin, and an elevated CRP. So just take a look at those labs for a second, because the question I'm going to want you to think about is, what are all the factors contributing to her worsening anemia? And I didn't tell you her baseline, but it's better than this. So thinking through that, think of all the different things that may be contributing to her hemoglobin dropping from baseline. Okay, so probably you all thought acutely of inflammation. We have a lot of evidence of inflammation here, right? We have the fact that she's having a flare of her colitis. She's been off her mesalamine, which acts as an anti-inflammatory, for a whole month. She's got an elevated CRP and an elevated ferritin, again, markers of acute inflammation. So we can definitely see that there's inflammation involved here. There is, I will say, also iron deficiency involved. And so even though the iron level and the ferritin level are technically normal, they're on the low normal range and they're unreliable with acute inflammation, particularly the ferritin, but the iron as well. And so really what we want to think about is, what is her iron saturation? When ferritin is unreliable, looking at this iron saturation, if it's less than 16 to 20, and I generally use the 20% cutoff, then I will say that there is an element of iron deficiency. In addition, with her inflammation, another acute marker of inflammation is going to be hepcidin, if you think about the iron pathway. And hepcidin inhibits iron absorption. So increased inflammation, increased hepcidin, decreased iron absorption. Same thing with her PPI. We remember that iron needs an acidic environment to be absorbed, which is one of the reasons we take vitamin C to help absorb iron. But her PPI is eliminating her stomach acid. So another reason that her iron's not going to be absorbed, and she's going to be either whole body definitely or functionally deficient. And then finally, she probably has chronic blood losses. Maybe she has some low level of bleeding from colitis. She's still in reproductive age, so there's probably some blood loss with menstruation. And again, she's losing iron through this. And then finally, she's got chronic kidney disease. And we know that the kidney produces the hormone EPO, and so she's going to have lower production of new blood with her chronic kidney disease. So she's got lots of reasons to have worsening anemia here. So, you're going to pull the trigger and do a full iron deficiency, full anemia workup. Are you also going to test for B12 and folate deficiency? Well, one might argue the microcytosis you can get from the iron deficiency component could, quote unquote, average out the macrocytosis from B12 and folate. So a normal MCV may be masking a number of deficiencies. So, okay, maybe we should test for them. However, in this country, folate fortification in foods, in almost all foods, look at any food you eat, look at the label, anything that's processed at all is fortified with folate since the late 90s. And so after this, after fortification became very common, almost 15 or more than 15 years after, a study was done of over 2,000 inpatient folate tests. And the most common reasons this folate test was ordered was normocytic anemia, macrocytic anemia, and altered mental status, so things that will frequently trigger us to order a folate level. Only 2 of those 2,000 tests, so 0.1%, were in the deficient range, and only 7 of 2,000, or 0.3, were in the low normal range. So this is again showing that once folate fortification became mandatory, almost nobody these days in America is folate deficient. And of those 9 that were, it was predictable based on their risk factors. So they either had severe alcohol abuse or chronic malnutrition and malabsorption, and it would be a good reason for you to check their folate level. So to get one deficient test result, you had to spend $158,000 ordering folate tests. So one would argue that's probably not a good use of our limited resources, knowing that folate deficiency is extremely rare in patients who are not malnourished, not alcoholics, not necessary to order folate tests in these patients. Okay, well, what about B12? Is that useless as well? Should we get rid of that? Well, no. B12 deficiency is much more common, and depending on the population that you're looking at and the cutoffs that you're looking at, between 5 to 40% of the general population is going to be B12 deficient. So that's much more worth looking at. Again, PPI is a risk factor for B12 deficiency for the same reason: decreased acidification, decreased absorption. And so we are going to test this patient for B12, or at least I would. But we also need to remember that a low normal B12 level can mask a functional B12 deficiency. And so a better test for B12 deficiency is going to be an elevated MMA level. And the guidelines generally say skip ordering the B12 level, just go right to ordering the MMA, save yourself a step. The cost of those 2 tests is pretty equivalent. Okay, well, we think she has anemia of chronic disease, anemia, or iron deficiency anemia, so how are we going to treat her? Well, we all know treating the underlying cause is what's most important for chronic disease. So we're going to address her colitis, we're going to restart her on her mesalamine, probably give her steroids for her flare, etc. And she's going to need some iron. So we've just said, even though she does have some chronic inflammation, there is a component of iron deficiency here. And this is not just for her iron deficiency. Most patients with anemia of chronic disease, again, due to that hepcidin, it's going to inhibit both iron absorption and transfer. They're going to be functionally iron deficient. So no matter how much iron they actually have in their bodies, they're not able to use it. And so supplemental iron is a valid and evidence-based treatment for anemia of chronic disease. It just depends on how you give and what your cutoffs you use for the treatment with your supplemental iron. So in general, your goal in a patient with just anemia of chronic disease or an overlap of ACD and iron deficiency is going to be get your ferritin greater than 100 and get your saturation greater than 20%. Anything less than this, and you would go ahead and supplement with iron. And then you could also technically use EPO if the levels are low, given that she has chronic kidney disease. But generally, this is not done unless the hemoglobin is less than 10 and persistently less than 10 after other treatments. So we're going to ignore that for now. So let's talk about oral iron. So based on the amount of iron depletion we have in our body and the amount of iron in oral iron pills, it takes months to replete our iron stores. We just said that the absorption of this oral iron is highly dependent on the acidic environment, the presence or absence of food, the presence or absence of other medications. We all know iron interferes with quite a lot of other medications. Also, oral iron is poorly tolerated. So in one study, up to 70% of patients experience GI side effects. And you might say, oh, a little nausea, a little constipation, stomach upset, not that big of a deal. But it is a big deal to these patients. And because of this, adherence to oral iron, full adherence to what we prescribe, is actually quite low. To try to deal with this problem, manufacturers have developed these slow release or enteric-coated oral iron, but it also decreases the absorption. So you're kind of making more of a problem when you're trying to address the problem. And then finally, as we've been saying, the elevated hepcidin levels because of the inflammation is going to inhibit our absorption of oral iron. So no matter what we give somebody, they're probably not going to absorb it well, and they're just going to be miserable from the GI side effects we give them from the oral iron. That being said, if somebody can tolerate oral iron, right, there's 30% of patients here who can, and they're not taking a PPI, they're not inhibited by other medications, they don't have a significant inflammation component, we can certainly and do certainly use oral iron. We see quite few patients on it. So let's talk about the dosing of that oral iron. This is actually one of my favorite studies for its just general cleverness. Researchers took a group of iron deficient women, and they were just iron deficient, they weren't anemic, but they were lab tested iron deficient, and they gave them radio-labeled ferrous sulfate, which is one of the main oral iron formulations that we use. Same dose, same number of pills, but they either gave them the pills once daily or once every other day. The cumulative dose absorption, so how much iron actually entered their bodies, was lower in the daily group than the every other day group. So, a good 40 milligrams difference, which is significant when you're talking about iron. And this is just, like I said, same number of pills, just different spacing of the medication. And they also measured the hepcidin levels, and they were significantly higher in the daily group. So when your body absorbs iron, as a result of that, it upregulates hepcidin. The more you take iron, the more hepcidin, the less you can absorb iron. So there seems to be a sweet spot at about every 48 hours or so, where you get the maximal absorption since your last iron pill. And there was a separate study by the same group evaluating twice daily dosing, because that's commonly what we see 2 or 3 times daily, and the hepcidin levels was even higher. So again, reinforcing the fact that the sweet spot seems to be 48 hours from the last dose. So just in case that wasn't clear, optimal dosing of oral iron is going to be every other day, or I usually tell patients Monday, Wednesday, Friday. Okay, but let's say we don't want to use oral iron. It's kind of a pain. I can't remember to take things Monday, Wednesday, or Friday. Half the time I don't know what day of the week it is. I don't want to take a medication for months at a time. It upsets my stomach. So let's talk about IV iron. Many patients who do not respond to oral iron will respond to IV iron, even if they have baseline high ferritin levels. Because remember that ferritin is going to be an acute phase reactant as well. So it's not just telling us about our iron stores, it's telling us about inflammation. We can replete the entire full body iron deficit much more quickly. And again, we have a captive audience. We can ensure adherence. The patient can't go anywhere, they get a little infusion, and you're sure that they have received the entire dose of the iron that you want them to. So between the time and the adherence, this makes up for the increased cost per dose between IV iron and oral iron. So cost effective wise, it is cost effective to give IV over oral. We used to learn, and I don't even think you guys learn this in med school anymore, that one of the reasons we didn't use IV iron was allergic reactions. It's an old formulation of iron that's no longer available, and reactions are exceedingly rare, so not even really consideration these days. You can have mild infusion reactions. Generally, if you just slow the infusion rate, that's going to treat your infusion reaction. Occasionally, you want to use prednisone. This is not a histamine-mediated infusion reaction, so Benadryl is not going to help, but steroids will. And one thing that we need to remember is that IV iron should not actually be given with active infection. Although this is more theoretical than actually proven, bacteria need iron to survive and multiply. And so if someone has an active infection, especially a bloodstream infection, you don't want to feed the bacteria. So wait till they're no longer infected. So in practice, if you want to, you can calculate the total body iron deficit. But as a general kind of rule of thumb, a total dose of 1,000 milligrams is usually standard and about what patients need, plus or minus, and you're not going to overdose anyone on iron with this dose. Here in our hospital, our formulation we use is called ferric gluconate. We don't need test dosing for it. It's generally given over an hour. And so when you order it in the computer, the typical dose that pops up is going to be 125 milligrams, but it's safe to give up to 250 milligrams at a time. So when I order this, what I typically do is just order 250 milligrams daily IV for 4 days. And then 4 days later, the patient's completely iron repleted. You don't need to worry about oral iron for months or more. There are newer iron preparations out there that allow for a single dose infusion of that 1,000 milligrams. And you will likely see this in the outpatient setting, and hopefully someday we'll get it here when the cost comes down. All right, we're almost done, almost wrapping up. And sorry, I just realized I'm a tad over time, but I have to show off my love for the Cardinals. This is us at the NLCS last year. If you guys are baseball fans and were in DC last year, you know the Cardinals lost, the Nationals won, but that didn't stop us from going to the game. And now my son's playing t-ball, which is the greatest thing ever. Okay, so let's go through some take-home points, and then we'll have questions. So, definition of hypertension only applies to chronic hypertension in the ambulatory setting. The benefit of lowering that blood pressure occurs over years to decades, not the hours to days they're here in the hospital. There's no evidence that treatment of hypertension is beneficial except in hypertensive emergency and organ damage. Do not prescribe IV antihypertensive medications in the absence of end organ damage. We have much better ways of addressing that. And really the best way to address elevated blood pressure in the hospital is good medication reconciliation and good communication with the PCP. Regarding COPD, LAMAs are our first choice treatment for preventing further exacerbations in patients at high risk, so those with 2 or more per year. For controlling symptoms, you can use either LAMAs or LABAs or both, whatever helps the patient's symptoms the most. ICSs are appropriate as a third long-acting agent in poorly controlled COPD, or a combination when COPD and asthma significantly overlap. Don't use LAMAs and SAMAs together, especially in patients with BPH or urinary retention. And early addition of long-acting bronchodilators and acute exacerbations can decrease resource use, including length of stay. And then finally, regarding anemia, Do not routinely test for folate deficiency. You might consider it in the case of severe alcohol abuse or severe malnutrition and malabsorption. Otherwise, it's wildly not cost effective. Most patients with anemia of chronic disease are also functionally iron deficient due to elevated hepcidin and other mechanisms. Treat to a ferritin greater than 100 and the saturation greater than 20%. Oral iron is poorly absorbed, poorly tolerated. If used, use no more than once daily, and every other day is probably superior. And here in our hospital, we use ferric gluconate, order it as 250 milligrams IV daily for 4 days.